start the recording. Jake will be impressed if he comes on. Oh, he is on the call. Starting the recording. And
hi, Rick.
Hi, Jake. And who do we have on the telephone?
John Appler, Rick.
John Appler, number two. Number two, Jake. John Appler. And who else do we have on the telephone?
Jim Harrington, Rich.
Jim Harrington, number three. And
Got it.
yes.
Hang on a second. Hang on.
Are you telling? That's Paul Frieda. Are you telling us to hang on, or should we continue?
No, that was me. Give me time to type the names in.
Oh,
that was Jake.
Okay. Okay. Are we ready, Mr. Hannum?
Yes, sir.
Okay. Who else do we have on the telephone?
Sylvester, man.
Sylvester is number four.
Got it.
Okay. And then we have one other person. If you'd like, if you want to identify, that's fine. If you just rather stay silent, that's just fine too. So let me write down all these names, and then I will do a roll call, and we'll get started. Bill Franklin, Brian, and thank you everybody for filling your names in on the GoToMeeting. It really helps. Ooh, Ken Mason. To what do we owe this honor, Mr. Mason?
You showed his face, and then you mentioned his name, and he disappeared.
Rick has that effect on some people.
That's right. Yeah, particularly Mason. He's obviously stepped away, otherwise he would have been making some rude remarks already. Okay, and Sylvester. All right, so I think I've got everybody written down here. So let's try. So I see Jake and Len, John Appler, Bill Franklin, Brian, Dennis Correa, Ken Mason, Gary, Rick, and Sylvester. Did I miss anybody?
Jim Harrington.
Oh, Jim Harrington.
Miss me, Rick.
I did miss you, yes. And
Yeah.
I'm going to give you some time at the beginning, so don't worry. I haven't.
Okay, yeah, thanks, Rick. Sure, that's fine.
And Brian and Rick, those are two names that are not that familiar. Have either of you been on the call before? Brian, have you been on the call before?
Yes. A few weeks ago, I came on, gave my story.
Okay. Yes, I think I remember. I do remember. Yes, I do. I absolutely remember. And Rick, have you been on the call before?
No, I have not.
Okay, well, welcome. We'll give you some time up front, but we have some business to take care of first. What we usually do, Rick, is that, you know, if you haven't been on the call and you would like to, then we'll dedicate the first 20 minutes or half hour to you, and you can tell us a little bit about your situation if you're comfortable doing so. So think about that a little bit, but I would like to I'd like to give the floor to Jim Cammon. I just want to say a couple of words to Jim Harrington. I'd like to just say a couple of words myself about Jim Cammon, who we found out passed last week. Jim had a really rotten genetic hand. What can, you know, can I say? I think that's probably summarizes it better than anything. I mean, this was a man who didn't have really bad prostate cancer, but it did come back. It came back in a fashion that was pretty treatable. He managed quite well going to Johns Hopkins for some time. Seemed to be under control with a second-line anti-androgen. But in the meantime, I had a bunch of other cancers, melanoma. He had a cancer on his retina, which was probably retinoma. But when they did some studies, they found out that he had this retinoblastoma mutation that some of you have, which is unfortunately associated with aggressive prostate cancer. And then in August, when I was driving back from Los Angeles and San Diego, he called me and said that he'd just been diagnosed with spindle cell cancer, which was a new one on me. I didn't really know too much about spindle cell. And it turns out that spindle cell is a very unusual cancer. There's not more than 100 or so cases, I think, totally on record. And so he had some issues at Hopkins, and we switched him, and we brought in a really fine doctor, Paul Korn, at MD Anderson. Sadly, Jim never got to meet him because he really just got too sick on the carboplatin and the docetaxel, and he sort of went downhill relatively quickly. And Len, who is wintering down pretty close to Venice, in Sarasota, was able to go visit with him a couple of weeks ago, and could see that Jim was really sick. And then he passed last week. I had the pleasure of meeting Jim and Pam at PCRI about 3 years ago when Dominic, God rest his soul, organized a dinner and inveigled me into driving down to Los Angeles. And I met a whole bunch of people in doing that. And Jim Cammon was one of the people. So we had physically met, and which was great. But of course, I knew him really well just from the online communications and attending some of his appointments. So he fought a really valiant fight, and God bless him. He also brought a bunch of people to us because he was very early. He was a very early participant in these calls. And one of the people he brought to us, I believe, was Jim Harrington. And Jim, I know you'd like to say a few words. So,
Well, I just have a few words. Thanks, Rick. I just want to tell all the guys on the call that I did know Jim, but I did not know him from Florida, and I did not see him in these final days, but rather knew him from New Jersey. He was a staunch supporter of our Us Two group in Morristown, New Jersey, and he would come all the time to sit at our advanced cancer table, always cheery, always with a smile, always willing to help, and always willing to get help from us. He was such a fun guy, and when he was in New Jersey during the warmer months, and then he would go to Florida when it was colder. And I think it's just a shame. Of course, we lose a really good guy to just a terrible disease. And all I can hope, Rick, I'm not sure, but is that he didn't suffer or didn't have a lot of pain in the end. But he was just a wonderful fellow. He was so upbeat. So he had always this kind of cherubic look about him, and always smiling and so forth. And always a big supporter of us two in Morristown. I think the largest Us Two in New Jersey. So it's a pretty good sized group. And Jim always attended. That's all I have to say. We're going to miss him. We're going to miss him in New Jersey. And he was a good friend, and he just, he fought it hard, but we'll miss him. That's all, Rick.
Have you let the New Jersey group know, by the way?
No, we haven't. No, I have not. The leader is down in Florida, I think, right now, Bill Grassmeyer. But we have a meeting tomorrow night, so I'll go and I'll tell the guys. No, not yet. I think Bill Grassmeyer, the head of us two here, was going to try to see him in Florida. So maybe he did, but he's been down there for the past month or so.
Okay.
I'll let him know.
Thanks. Thank you.
Yeah, sure. You're welcome.
Is there anyone else that would like to say anything about Jim before we move to Rick?
Rick, it's Len. I just want Jim Harrington to know that next time he meets with his Morristown Us Two group, that Jim's wife, Pam, I don't know if you've ever met her. She's a wonderful, warm.
I think I have. Yeah.
Yeah. She has told us that in lieu of flowers or any other kind of gift for Jim, that she has requested that people donate to the Answer Cancer Foundation. So I'm going to pass that on to Morristown.
Yeah, I'll do that. I'll do it. Thank you.
Thank you.
Len, when is the mass for the memorial mass for?
It's tomorrow morning, Rick.
Okay.
I had to scramble and get myself a white shirt and black pants because I came down here not expecting to do anything formal.
Oh goodness.
No tie, nothing,
Jim, by the way, left his body to medical science, but there is a mass. There's a memorial mass for him tomorrow. So.
Rick, do we know where that mass is going to be?
Yeah, I do.
If
It's okay.
If you could put it in a chat window, I can look it up.
Oh, okay, sure. I'll do that.
Thanks, Bill.
Yeah, appreciate it.
Okay. So, Rick, are you comfortable in telling us a little bit about your background, your diagnosis, your age, where you are in the journey, and how perhaps we can contribute to improve your situation?
Thanks for the opportunity. I don't know where to start. I don't know how deep you folks get in on your first time on the call. I'm 77 years old, diagnosed about 10 months ago, regular routine physical. I was one of those people that slipped through the cracks where for a couple of years they didn't check my PSA. And fortunately, I had a new physician, and she had the PSA done. I came up with a 28.4 PSA. Did a digital, and there was a lump. She then sent me to the urologist. Urologist put me on Casodex. Then I went on Lupron. Had 41 IMRT. Had the fiducials put in, and I also did Spacor, which was a favorable experience for me so far. After I just had my, about 3 months ago, I had my second 6-month Lupron shot. After the 41 IMRT and the Lupron, my PSA is 0.95. I wished it was down closer to 0. I go back to my urologist in a couple of months for a third Lupron shot. I don't know if that is enough for you or anything else you might like to know.
Well, it's a good start, but we'll ask you a few questions and it'll tease out the other information, Rick. First of all, what part of the world do you live in?
I'm in central Pennsylvania, being treated by physicians at the Geisinger Medical Center, which is an excellent medical center. I don't know what the reputation is for cancer, prostate cancer treatment, though.
And what was your, tell us a little bit about your biopsy. What was the Gleason score? How many positive cores, et cetera, et cetera?
Okay, as I said, my Gleason was 9, 5 plus 4, 7 of 12 came back positive. I've forgotten the exact percentages. I know at least one was 70%.
Mm-hmm.
Some of the others were much smaller.
Mm-hmm. And did you consider any other types of radiation, or did you just decide? Did you have the opportunity to think about other types of radiation, or did you just go straight to the IMRT?
No, I went right to the IMRT. I checked with my family physician, and she was comfortable with that. But no, I didn't explore anything further than that. No.
I mean, it's a solid choice. A lot of times for men who have the sort of diagnosis that you have, 5 plus 4, 7 out of 12, they combine the IMRT with some sort of brachytherapy, either high dose or low dose brachytherapy. That actually is what I did, and I think maybe some others on the call. But it's good that it's very good that they put you straight onto the androgen deprivation therapy. Are you still on the Casodex, or did they take you off and just leave you on Lupron?
No, I was just on the Casodex for the first 2 weeks when the PSA spikes.
Yeah. Excellent. And so, how long have you been on the AD? How long have you been on the Lupron now?
Just about 9 months, 10 months.
9 months. And how are you managing?
Compared to what I understand other fellows are doing, I think I'm doing pretty well. The worst part of it for me has been the hot flashes. If that's the worst thing, I can certainly live with that. This second time around, I have more fatigue. But other than that, leading a pretty normal life. I try to work out 3 or 4 days a week. I do spinning and I do weightlifting.
Good. Well, we can talk a little bit about the hot flashes and maybe give you a couple of thoughts on how you might be able to manage them. It's great that you're doing the exercise, because that is, I just can't tell you how important it is. We can send you, or you can look on our website, and there's a really good pamphlet put out by UCSF on hormone therapy, which we feel should probably be given to every man that's put on hormone therapy, certainly for more than 3 or 4 months, and it'll give you a pretty good feel for what hormone therapy entails. I mean, a lot of it you know already. It's not unusual that you're more fatigued this time. It's really not the fact that it's another Lupron shot. It's just a time thing. And the longer you're on it, the more fatigued you're going to feel. I think the big issue and the concern is that your PSA is at 0.95. It didn't get down below that. Did they? I see you had 41 treatments. Did that include the whole pelvic girdle? Did they radiate your pelvic girdle?
I don't know, to be honest with you. I haven't heard that term, so I don't know.
Okay. So it would be good to find out. That there should be a radiation report, and you can get hold of that. But what that means is that they radiated not only the prostate and the prostate bed, but they radiated right the way across your pelvis, so that all of the lymph nodes were radiated as well.
I will ask that question.
Yeah, and the fact that you had 41 treatments suggests that that's what they did, but it's not certain. But my guess is that that's probably what they did, and if they did, it was the right thing to do. At this point, let me ask you, what questions do you have for us, and how can we support you?
I don't know. Again, I'm kind of curious to sit in on this discussion and see where it leads us. My urologist told me that they would give me up to 4 6-month Lupron shots. As I said, I've had 2, so I have 2 more to go. And I guess the question is, after the 4th one, after that 2 years, if the PSA is not down where it should be, what is everybody else's experience? What do they do?
Okay, who would like to wade in and speak to Rick?
This is Dennis.
Please, Dennis.
Yeah. Rick, I'm 72. I had a Gleason 9 a couple of years ago and went through chemo. Of course, before that, they did the imaging, and I didn't hear you mention what kind of scans you had or anything to conclude that, you know, it hadn't left that area and has not metastasized. But Gleason 9 is pretty high, pretty aggressive.
Yeah, it is. It is. I'm sorry, it is high risk, aggressive. I had the bone scan and the CAT scan. Everything came back clear. I'm NOMO, I think, is the term.
Good. Well, that's you sound like you're doing the right stuff then. Good. That's all I had.
Anyone else like to talk to Rick?
Yeah, this is Len. I'd like to ask Rick a question.
Yes, please.
So Rick, how is your PSA continuing to drop while you're on Lupron, or has it kind of reached a nadir? What's going on there?
Actually, they only tested it the one time after I had finished the 41 IMRT, and just before I got the second Lupron shot. And as I said, it went from 28.4 originally down to 0.95. I guess in the next month or two, I'll be getting another PSA test.
Well, so when was that 0.9 reading?
That was about 3 months ago.
Well, I'm sure everybody on this call would agree that you should have a PSA check at least once every 3 months.
Minimum.
Right. At minimum once every 3 months. Okay.
Minimum.
Yeah, and if your PSA is no longer dropping, then the typical thing they do will add a second line anti-androgen or ADT drug, which could either be Xtandi or Zytiga. I don't know if you've heard those names before.
Yes, I have. I've read about them online. Yes.
Yeah.
Now, do you do that in conjunction with the Lupron, or is that instead of the Lupron? Okay.
No, in conjunction. And so, yeah, I would give your doc a call ASAP and say, hey, it's 3 months. I think I need another PSA.
All right, I will do that. Thank you.
Rick, this is Peter.
Go ahead.
Yeah, I understand that your urologist is managing your case and directing it?
That's correct, yes.
Yeah. Do you have access to a good medical oncologist?
Yes.
Yeah, I would start working a relationship that way. If you're a 5 + 4, 9, I would consider just working with a really good medical oncologist, because they're going to be with you for a while, and it could get complicated.
Okay.
That would be my guess. I mean, that's what I'm a 4 + 5, and I've been for 4 years now, and I will always be. But my genitourinary oncologist manages my case. I go to other radiation guys and so forth, but they're experts at this field, and you're gonna, as Len just said, you're gonna probably have to eventually go on a second line anti-androgen, something stronger than Lupron. And I get my PSA and testosterone checked every month under the direction of that medical oncologist. So I think you probably want to get more, I don't know if I want to use the word aggressive, but you want to get a closer handle on this than the urologist might be able to do.
All right, I'm glad you raised that. That is a question that I've been having. I didn't know who's driving the bus here, whether it's the urologist or I have a radiation oncologist that I'm very comfortable with. But are you saying that I should be going with a medical oncologist?
Not just a medical oncologist, a medical oncologist that specializes in prostate cancer, and they are called genitourinary medical oncologists. Maybe Jake or Peter or somebody, would you be kind enough to put that in the chat box for Rick? A genitourinary medical oncologist. Now, the issue is that they're not the easiest to find. And you're in central Pennsylvania, so you have options at Fox Chase in Philly. We can recommend somebody at Fox Chase. I don't think there's anybody that we know in Pittsburgh. Are you about halfway between Pittsburgh and Philadelphia?
Just about, yeah. Probably Johns Hopkins wouldn't be bad for me.
Okay,
Yeah,
Hopkins, great, and we can.
Hey, Rick,
Yes.
this is Jim. Where are you in Pennsylvania? Why not tell us the town? I mean,
Yeah, Lewisburg, Pennsylvania, where Bucknell University is.
Okay.
because as Rick says, he may have to try to find somebody or go to a larger city to find this right kind of meadows.
Okay. Well, if you can get to Baltimore, then yes, you've got good options, and we can suggest some names for you at Hopkins. Some good, some bad. Jim Cammon, God rest his soul, was not at all happy with his guy at Hopkins, but I will also say that his guy was, one of the best recognized GU medoncs in the country, but he didn't do great for Jim. But there were other people at Hopkins that we do like, and we can give you names at Hopkins. We can certainly give you names at Fox Chase, and we can give you names at Memorial Sloan Kettering. Those are probably the three closest to you.
Yeah.
Either New York City, Philadelphia, or Baltimore. Now, you don't have to see your GU medonc all the time, as Peter Kafka will tell you in a moment. But you need them on your team, and there is a controversy in the sense that the urologists don't like to give up their patients. To some extent, there is a financial conflict because they make money off of these Lupron shots. They're a cash cow for them.
Okay.
And so, don't be surprised if the urologist says, well, what do you need them for? I can manage this. And there are some pretty well-known urologists around the country who consider themselves to be experts in managing advanced cancer. If it were me, we don't give medical advice on this call, but we talked from our own experience. If it were me personally, I would never have a urologist manage my care.
All right, I appreciate that.
Now, I think that Len's advice is really good, and Peter's. Get yourself tested on a regular basis, once every 6 weeks, once every couple of months, and also ask them for a testosterone test, because you want to make sure that your testosterone has fallen to a castrate level, and you don't know that. You should have done, but you don't know it. So if for any reason the Lupron isn't working properly, then you could still have higher than a castrate level in your body, higher than 20, and maybe higher than 50. 10 years ago, 50 was the cutoff. Now they like to see you below 20, and they measure to below 20. So you should be getting your testosterone tested pretty regularly, along with your PSA.
All right, I will do that.
But I think, Rick, that to place a GU medonc on your team genitourinary medical oncologist on your team is a good move, and I strongly recommend that you do that. Jake has been good enough to spell it out for you in the chat window, so you can see. Genitourinary is not a word that we generally use in our vocabulary, so if it stumped you, don't worry, it stumps everybody.
Okay.
What I would say is that keep talking to us on this call. If you would like to be included on, we have a distribution. Did you see us on the Inspire site? Is that how you heard about us?
Yes, it is. That's how I found you.
Yep. So you can in the chat window you can send me your email address and your last name, and then we'll get you onto the list. And then each week before each meeting, we send out a notice, and you can join. You don't have to join, but at least you know what's going on, and we can help you if you need names. We can give them you on this call, or when you're ready, we'll give them to you on the call, or you can email us and we'll send them to you, whatever's the most comfortable for you.
All right. As we speak, I'm sending you my name and an email address.
Super. So, anybody else? Would anybody else like to say anything or any suggestions in terms of doctors? Tom Van Zandt is not on the call, is he? Did he come in? No. Oh, Tebow's on. Hey, Tebow. We'll give you priority because we don't want to lose you. We don't want to lose you before you go off with the kids. So as soon as we're done, we're going to talk to you. We want to find out what's going on. No, I don't see Tom Van Zandt. If there is a fellow who lives in the Poconos who gets treated at Fox Chase. His doctor's name is Gainesman, Geynesman. I think he likes him. And sometimes he'll come on late. So if he does come on late, we'll circle back to you, Rick.
Okay, thank you.
Okay. Yeah, and thank you. I've got your, I see your email. So anyone else like to talk to Rick before we move on? Okay. So I'm gonna move out of before I do the roll call with everybody. I want to catch Tebow because a couple of times I've seen him on here before and then he hasn't been able to stay on, and I think we're all anxious to find out how you're doing on your trial, how you're feeling, any results.
Yeah, my
Bring us up to date.
So I just get so tired I can't stay awake anymore.
Oh.
I had my chemo before the transplant. That was December 20th through 26th, something like that. The actual transplant was December 28th, where I got a big bag of bone marrow from some woman in another city. And I had a reaction to the cyclophosphamide chemo on my hands, a rash, which wasn't too bad. And they said it's rare, but it'll go away like a sunburn. And then like a day later, I had spasms of pain in my leg, and was admitted, and they gave me a bunch of morphine. And everybody has something that goes wrong when you're not feeling well, when your immune system's not working. And that's just it for me, that I have left hip that's got prostate cancer in it. But doctors did their own scans, and they found a fracture in my spine and blamed it on that. And I really don't think that's true. It's a small fracture. And then I got admitted again for having a fever, and I was not eating very well, and I was hallucinating at the hospital. I don't even know how many days I was there. It was 5 or something. And yeah, I could barely think when I got home. But my appetite has gotten better. My weight has stopped dropping after 24 pounds and 4 inches of pant size. And I have a rash across most of my body now. The doctors weren't able to connect it to any of the drugs I'm taking, so they figure it's GVHD. So they're giving me a little bit of steroid to put the brakes on that immune system. And it's itching less, but I still have a rash, like clear from my knees up. You can barely see it on my head, but it's a bit visible. Mostly it's on my torso. But overall, I'm doing pretty good. I'm getting to skip days now. I don't have to go in every day. It's every 3 days a week now.
And
so
when you go in, what are they doing? Giving you additional chemo, additional bone marrow? What are they doing?
They take some blood, and then they wait for the results, and then they figure out whether I need any different drugs or higher doses or lower doses. And they interview me about my symptoms every time, and so you can see what's working and what's not working. And right now I'm relatively stable, so I get to have whole weekends off.
And what drugs are they giving you, right? What is the drug other than the steroids? What other drugs are you getting right now?
Some of them, I don't even understand them all. They've got like anti-rejection and antifungal and antibacteria and my usual opioids and
right.
I can't even name them all. They're always changing. Every time I have a problem, they're like, well, this drug sometimes contributes to that, so we'll take you off this one, put you on this one instead, in the same category.
And how often do you see Sam then meet on a regular basis? Or?
No, he has almost nothing to do with the transplant part. I saw him once because it was time for me to get a PSA test and get my regular Eligard shot. I haven't gotten the PSA result yet, but I did get the Eligard today.
And did where are you with the testosterone? Have they started playing with the testosterone yet or not?
No, that won't happen until day 60. We're like at day 35 now.
Okay. Just to digress for a second, if I don't know if you heard the conversation with Rick. If you were selecting a GU med at Hopkins, who would you recommend?
Well, my main guy is Antonarakis. He's pretty good.
Yeah. So that's a really good name if you can get into seeing Rick, is Antonarakis. This trial, which I'll explain momentarily, that Thibaut is doing is out of Hopkins. So you're hearing it from the horse's mouth, as it were. So
guy to do this. There's a first guy that's doing pretty well.
Oh, good.
He's had.
What about results? Have we seen any impact on your PSA or?
I haven't seen my result yet.
Uh-huh.
I'll have to ask him when they did it. They were supposed to do it like a week ago.
Okay. So you're still in the dark, basically. Do you just want to give?
But
Yeah, go ahead.
Immune system's not too weak, you know, with his GVHD. So it'll probably do something
Good,
to
good.
the cancer.
Do you want to just give a for those who are on the call who don't know about the test that you've been doing? Do you feel strong enough just to give them a quick resume of what you've done or what you're doing?
Well, it's basically the first time in a long time that bone marrow transplant has been used to attempt to treat prostate cancer. And after the bone marrow transplant is done, we immediately start bipolar androgen therapy. So we'll have like 4 months of that until the trial is officially done. And then after that, I could, you know, keep on doing that if it's working, or, you know, we just treat it as normal after that.
Thank you. So, guys, I'm opening it up. Who would like to talk to Thibaut?
This is Len Thibaut. I think you may have talked about this some time ago before the procedure, but I'm afraid I don't remember. Is the type of bone marrow transplant that you're undergoing different from what they would use for, let's say, a blood cancer like leukemia, where they completely ablate your bone marrow with high-dose chemo and then repopulate your bone marrow with the transplant? Is kind of giving you a whole new immune system, or is it different?
It's a little bit different, but there are other people that get the same type for different, I don't know exactly which cancers, but basically they're giving me not a huge dose of chemo, just enough to prevent my old immune system from beating up and rejecting the new one. So they didn't, at the time I got the transplant, I still had an immune system, but it wasn't, you know, I still had white cells, but it stopped producing new ones. And eventually I got down to 0 white cells, and now
We lost you. We lost your voice.
sorry, the normal range of white cells is 4.5K to 11K, and I'm at like 3K. So that's the new immune system. And they're doing another test to just verify that that is the immune system and not the old one. Considering the GVHD rash, then I'm pretty sure it's the new one.
Yeah, very good.
For those of us who aren't good on the acronyms, what is GBHD, please?
That's graft-versus-host disease.
Ah, yes.
If it's
right.
really bad, then
Yes.
that means your new immune system treats your
Right.
things, and you can die from that.
Right. So how does it look like you're doing in terms of accepting or rejecting, and when will you know for sure that the graft is taken?
Well, when I stop getting GVHD symptoms.
Okay.
Like the guy that did the first one, he just has like one symptom, and it's relatively minor. but it is chronic so far.
Okay. And how far ahead is he than you?
He's like 4 months ahead.
Okay. And have we seen? Are there any results from him that can be shared?
I know that his PSA has gone down, but it's not all the way down.
Right.
This is Jake. First of all, I'm glad to see you. You look good. I like the haircut. I wanted to ask you a question though. Are you still getting the routine cancer treatments like Lupron, or have they ceased that?
Yeah, I'm still getting that. I got a shot today.
Okay. And then like in another 30 days, you'll get your first BAT.
Right.
Is that correct?
That's correct.
Okay.
So yeah, we should just explain that this part of this is the bipolar androgen therapy, where we will be, or they will be giving Thibaut large doses of testosterone followed by ADT, and in the hope that it's going to regenerate the androgen receptors and make them sensitive again, so that some of the drugs that became ineffective will become effective again. Is that a fair summary, Thibaut?
Yeah. And more importantly,
Yeah.
the new system may recognize the cancer, whereas the system see it. It's just the big part of the job of the cancer.
Just can you repeat that? We lost you for a second right there.
Hopefully, the immune system a better chance of recognizing prostate cancer behind all of its ways of hiding.
Right. So the immune system's going to recognize the prostate cancer more easily. Okay. Anyone else? Would anyone else like to speak to Thibaut before we move on?
Okay, I'll be.
So what I'd like to say is we all, bar none, just wish you as much possible success as there can be with this, Thibaut. And keep showing up, because we love to see you. And you're in our thoughts. And, we're delighted that you've gotten this far and that you've stabilized. And we're thinking about you. Okay. All right. I am going to run down the list of who I think we have on the call. And if I've missed anybody, you'll tell me. So we see Jake, Len, John Appler, Bill Franklin, Brian, Dennis Correa, Ken Mason, Gary, Rick, Sylvester Mann, Jim Harrington, Paul Frieda, and Larry Fish, and Thibaut. Did I miss anybody?
Peter.
Oh, Peter. I'm sorry, Peter, if I didn't read your name out. Okay. So let me see who would like some time today. Jake, would you like some time?
No.
Okay. Len, how about you?
No, thank you, sir.
Okay. John Appler, we still have, we lost you last time. I apologize. We didn't get to you before you had to leave. And I know you still have the question about germline versus somatic, correct?
Hi, Rick. I'm driving. I don't know if you hear me or not, but that question's been solved. I have a quick question about 6-month versus 3-month shots for Lupron.
Okay.
And, that's all I have.
Okay. Bill Franklin, anything for you?
No, I was actually tried to ask Rick, the new guy, a question, but I lost my audio right at that minute. But
Okay. Well, I have one other thing to say to Rick, so let's just touch base with Rick 1 second. Rick, I wanted to just say to you that one good solution for your hot flashes is acupuncture, and you might want to look into that. Find a good acupuncturist that's in your area, and there are known acupuncture points, and this is complementary medicine that's been tested, and there are trials. If you need them, I'm happy to send them to you. But beyond that, just find an acupuncturist, and the only issue is that you sort of have to go for a top up every 3 weeks or so. But you may find that it helps you with your hot flashes.
All right, I appreciate that. We actually do have a good acupuncturist here where I live.
Great. We'll talk to her because she'll know, or he or she will know the points because they use them for the women, and you do get results. And I think we've even got guys on the call right now that have gotten good results from acupuncture. Bill, what would you like to ask Rick?
yeah, Rick, did I hear you say that they gave you a number of how many Lupron shots you're going to have? In other words, how long you were going to be on the treatment, or?
Doctor told me 4 6-month shots is the course. I don't know if that's cast in concrete or if that's just what he tries to do.
Yeah, it's very common. 18 to 24 months seems to be a number that's kicked around by a lot of different doctors. And the other thing I was going to say is Rick's suggestion about getting a genitourinary oncologist on board. I didn't get. I kept my urologist because I really like the guy. He's very approachable. He's good for me. But I also did get a genitourinary oncologist on my team, who happened to be the radiation oncologist when I got my radiation. So he was dual-hatted there. But yeah, I would try to find one of those, definitely.
All right, I will do that. I appreciate the suggestion.
That's it, Rick.
Thanks, Bill. Brian, one thing, I don't have your email address, so if you'd like to send it to me in the chat window, I'll make a note of it and we'll put you on the distribution. I'm sorry that I didn't get it from you earlier, so feel free to stick it in the chat window and just send it to me. And would you like some time today?
No, thanks. You should have my information, Rick, because you've been sending me the invites.
Oh, I have been sending you the invites. Okay, for some reason I don't have it on your. For some reason I don't have it on the record, but I'll find you then. Okay, then I will find you. Thank you. You're in Bartlett, Illinois, correct?
Correct. Yep.
Okay, I'll find you.
Okay, thanks.
Okay, Dennis, would you like some time?
No, I don't need anything, Rick. Thanks.
Ken Mason, would you like some time? I've never heard Ken Mason so silent. Are you there, Mr. Mason?
Yes, I'm here.
Okay.
Wait. Okay, cancel. Just a minute. Yes, I'm here.
Okay.
And I just need to listen.
Oh, you just need to listen. Okay. Then.
Well, I missed your lilting tones.
Oh, thank you, Ken. So nice. So nice.
You're very welcome.
So nice of you to say so.
Okay.
Peter, would you like some time?
No, I think I'm okay right now.
Okay. Gary, how about you?
Nothing tonight. Thanks, Rick.
Boy, you're a you're a quiet lot tonight. Sylvester, would you like some time?
No, thank you very much.
Okay, Jim Harrington, how about you?
No, thanks, Rick. I'm just fine listening, and but not tonight.
Okay, Paul Frieda, how about you?
I'm good, thank you.
Okay, and Larry Fish, how about you? Larry, are you with us? I think maybe
Is that better?
that's just,
Yeah, no, not. Sorry, Rick. I have nothing special tonight.
okay. Well, this is wonderful. We don't have we have
Okay.
we have plenty.
It was nice talking to y'all. Y'all have a good night. And
Well, John Appler, we have plenty of time to talk about what you'd like to talk about, and then I've got to figure out what we're going to talk about tonight. But we'll find something. I have an idea. John, the floor is yours for as long as you like.
Yeah, all right, Rick, thanks. Just a quick question. I'm due for my Lupron shot. I've heard several mentions in this call of a 6-month shot. I heard a concern last week about possible how even the dosage is applied when you get a longer-term 6-month kind of shot. What is kind of the consensus out there now? Are you better to go with 3 or 6 month Lupron shots for consistency of dosage?
Okay, Peter, this is in your this falls right into your bailiwick.
I've always gotten 3-month shots. I just feel it's easier to monitor that way. 6 months is a long time, and I think it might lose some potency at 6 months too. So my take is 3 months. I don't have any evidentiary type of stuff to go by it. I know they make a 6-month shot, but I find 3 months is perfect for what I did, and may well do again.
There is also a 4-month shot.
Right.
That's what I get.
Right.
Okay.
Correct. Yeah.
Hey, Rick.
Yes.
I popped in kind of last minute, so
Okay.
I want to say definitely 3 months. Definitely 3 months.
Okay. Say more.
Well, I did the last trip because of my insurance cycling. I went ahead and did in like December a 6-month shot or November a 6-month shot, and quite honestly, my testosterone level has popped up 3.5, 4 months in. My testosterone level popped up from, and I don't know, it almost doubled from 7 to 14. So I do think it loses some effectiveness the longer. The 6-month shot I don't think is, man, quite honestly, I'm going to go back. Paul Korn told me to take 3 months, and for whatever reason, I didn't take his advice, and I'm sorry I didn't.
I mean, from the standpoint of comfort, and I think it was Len that mentioned this when we spoke about this fairly recently. The 6-month shot is not as comfortable because they just put a lot more of the leuprolide acid into you, and so it's a bigger amount of fluid that you've got to absorb. So, Len,
I don't know if it doesn't bring your testosterone level down, it's pretty hard to then switch midstream and go to something else.
Right.
You have to wait 6 months before you can start taking Firmagon or something to take its place.
I didn't realize that. I thought you.
Very good point.
I didn't know that. I thought you could switch pretty readily. You're saying that if your PSA level is rising, that you cannot switch. Is that right, Ken?
Well, I don't know if it's a rising PSA, but my testosterone level doubled, and I was told just to wait the 6 months and then take the next shot and maybe take more, but definitely a 3-month shot. So I don't know. I'm not gonna go more than 3 months again.
Okay. I mean, I did 3-month shots, and I was fine with them, and they worked for me right the way through. I'm not a big fan of the 6-month shots, but it's really up to you. I mean, you know, the difference for you, John, is that logistically, it's more difficult to get the shots. I don't know. Can you get the shots on Maui?
Yes, you can, Rick. Peter's helped me find a doc for that.
Okay. Well, I mean, if you can do the shots on Maui, then you know, if it were me, I'd be going with the 3-month shots.
Yeah, thank you. I think that's a good conclusion.
Okay. Ken, would you like some time today?
Me?
No, Ken Anderson.
Oh,
Yeah.
okay, sorry.
Is, you know, what happens when bone mets start becoming painful? How does it occur?
Okay, good question. Let me look at
Does it
list.
time?
I'm just looking at my list and seeing who might have wrestled on this list with any pain from bone mets. Well, I'll throw it open. Has anybody wrestled with pain from bone mets yet? Okay. Well, let me tell you what I know from secondhand experience, from what people have told me, that you start to feel a sort of a fairly deep kind of throbbing, more of constant pain, rather versus a shooting pain. The pain is kind of ever present, is what I've heard. So it's a chronic rather than an acute pain. I think there is some acute pain that goes with it. Thibaut unfortunately just left the call. I think he was pretty tired. He would have been the guy to respond to you, because he certainly experienced it. Does anybody else want to talk about what they know about bone pain and the onset of bone pain?
This is Jake. I believe you are correct, Rick, about the pain being pretty steady. That's what my oncologist told me. And from one of the things that sent me to the doctor in the first place was I had lower back pain, because I did have Mets, and that didn't go away with the Lupron. But once I started the Xtandi, it did get better. So my lower back pain is better than it was once I got on the Xtandi, for what it's worth.
Now, did you have pelvic Mets, Jay?
Yes.
Okay.
I have a bunch in my spine, iliac wing, sacrum, you name it, I got it.
And that was, so you were symptomatic when you were diagnosed, in fact?
Yes.
Okay. Well, that's some first-hand experience, Ken. Are you experiencing some pain or not?
Well, part is low back, but I don't know if it's Lupron, because quite honestly, when I wake up in the morning, that part is pretty much gone. But I am experiencing some, and I do have one bone met in my skull, but I'm not sure where it's at. And, you know, the last 2 or 3 days, it's been kind of a pretty consistent, like now it's not hurting, but been pretty consistently kind of a pain. You know, so I don't know. I've started smoking, you know, CBD or pot to kind of help me relax at night and make me go to sleep, and it does.
Right.
But unfortunately, it also numbs me. So I don't like taking it too much because I don't know where the pains are. So I don't know. Right now, it's kind of lower back pain that's been kind of consistent, and a little bit of something going on in my skull.
When was the last time you got scanned, Ken?
And that's been a while. I'm scheduled to go in March back to MD Anderson, the mid-month. So the last time it was in August.
It's time.
Yeah, I know.
It's time.
So I'll go back and drop 15 grand and have a scan.
What kind of scan are you getting, Ken?
I don't. I'd have to. There's 3 of them that they put me through when I go over there. So I think it's an MRI, a bone scan, and a CT scan. I think.
And they're not. They don't do more elaborate ones with you.
I don't know what they are. The last one I had, they stuck some. I think it was an MRI. It was the elaborate scans. Unfortunately, I must admit.
Peter, to what extent are the more elaborate scans going to be more effective than a regular bone scan if you have bone mets? I mean, are the elaborate scans really more for seeing lymphatic involvement and very small involvement?
I think so. Yeah, I think it probably wouldn't be necessarily in Ken's situation, unless his PSA is rising and it's very low PSA. That would be my take on it. If his PSA is relatively high, then any kind of scan, regular scan or CT scan, should pick up any activity.
But your PSA isn't that high right now, isn't that right, Ken?
Yeah, I just finished all those rounds of IMRT radiation, and my PSA did not drop shortly thereafter. In fact, I was told like 6 to 8 weeks after post-radiation I could see a drop, and it didn't drop then, but it did just recently. It dropped 1 point. So it's down to 0.5. And Lucas said he anticipates the next PSA pull in 28 days or 27 days for it to drop again. So I don't know, my PSA has dropped farther, so it's 0.5, and
right.
Testosterone has gone up, but I don't know, these pains may not be anything related other than just Lupron or just general muscle pain. I don't know.
Mm-hmm.
I just want to have an idea of what I can expect when they do become pains.
Well, if your PSA is at 0.5, then a traditional CT scan or even a regular PET scan or a bone scan is not going to pick up much evidence of anything. But if you're looking to see if you really have bone mets, you might ask them at MD Anderson about trials for more elaborate scans. I know they have them going.
Well, Peter, I'd like to sort of unpack that a little bit. I mean, it's certainly true if you have recurrent disease and you have no indication of metastasis, that if you have very low PSA like that, you need one of the more sophisticated scans. But what I'm not sure about is if you do know that you already have metastasis, then I don't know whether that's still true, that you can't go with the less elaborate scans because there's already enough aggregation of prostate cancer cells that they can be seen even though you're on ADT. Do you understand the difference I'm pulling out here?
I hear you. I don't know. I can't comment on that. I don't know. But everything I read about the different scans seems to indicate that they're not effective with low PSA numbers, that you need to be, in the 1.0, 2.0 range.
Yeah, but I think that's to diagnose if you have Mets. If you already have Mets and it's been seen, it's a different situation. I think you're absolutely right if you don't have metastasis.
Right, but I thought the discussion was about, are these pains indication of bone mets, and or is it in Ken's imagination?
Well, no, because Ken knows he's already got bone mets, so there's evidence of bone mets. The question is, have they grown or not?
I see.
Okay.
Well, it's more like where are they also? You know, I know there's the last scan or the first scan that I had, there were 5 locations that they had commented were suspicious. So I can only assume suspicious means, you know, Mets. So I know where those 5 are, and one is in fact located on right above my eye, and that's kind of where I'm having some pain, kind of not all the time, but it comes and goes. And I'm told, like you stated, Rick, that it's more of a consistent pain. You know, it comes, but it won't go away.
Right.
But this one definitely doesn't stay. So I don't know if it's something else, or, and I guess that's a question for Korn. You know, I'll just send him an email and ask him. You know, first of all, I'll ask him whether or not there's any advantage to have some other type of scan.
Correct.
In March. If not, I should come early.
Right.
You know.
Right. Yeah, I mean, ask him what scans would be effective for you. And then the other thing to ask him is whether any spot radiation might be appropriate. I mean, you're still in a sort of an oligometastatic scenario, meaning you only have hopefully 4 or 5 spots, and so it's possible that they might be able to do some spot radiation. Thibaut just came back in, and this question is really right in the middle of his radar. Thibaut, the question that Ken Anderson is asking is, how do you recognize that you've got that you're getting pain from your bone mets? He has 4 or 5 spots, Ken, and he's starting to experience some pain, but he's not sure if it's from his bone mets or not. What was your experience in terms of recognizing the pain from your bone mets?
Well, I was having pain. I had bone mets in lots of places, in my hip and in my spine, but I was feeling pain mostly in my upper spine, and later learned that one of the Mets was pressing on my epidural. And so it really wasn't that all those Mets were causing pain. Pretty much all of them were painless. It was just because it was pricking on my spine in that one spot. That's why I had pain. So after I got a laminectomy, that pain went away, and now I feel a lot of pain in my left hip, but that's a spot that I've had problems with for many years before I ever got diagnosed with cancer. And I also have cancer there now, and I think these 2 problems are working together to cause pain. A lot of the times, Mets don't cause any pain. And usually there's something else to look for.
Yeah, I mean, that's a really great point that Thibaut makes, that a lot of times this is just pain is referred because the Mets are pressing on a nerve somewhere. You know, we've heard that pretty frequently. Thank you, Thibaut. Thank you. So, Ken, I think your game plan is spot on with Korn. By the way, I'm thinking with Korn, we probably should let him know. We need to let him know about Jim Cammon too. I'll send him a note because he was so great with Jim. But I will send him a note and take care of that. So, anybody else want to talk about what they know about bone pain or bone Mets? Any other of you who have Mets but are not symptomatic?
Rick, this is Jim Harrington. I have bone mets, so I've had them for a couple of years, all up and down my spine, and I agree. I don't have any pain from them, even though my doctor always punches me in the back, and it just does. I just don't have any pain. And in fact, I don't have any pain at all. So these bone mets really just sit there, and they're getting better with the chemo. So, but they're not gone. So no, I don't have any pain. I'm glad. That part's good.
Now, what are they doing in terms of scans with you, Jim? Because
well, I just had a CT to look at the soft tissue and my lymph nodes, and also a bone bone scan. And the bone scans don't change very much. I look at them when they're finished with the technician and about the hour of the bone scan, and then I look at them and I see them, and doctors see them, and they just say it gets a little bit better. The CT scans are a little bit more important with contrast, and that's where they can look for the lymph nodes, and they're going to do a biopsy this week, Rick, for Foundation 1. And they can reach the lymph node, so they say, and biopsy it using the CAT scanner, and then very slowly move the probe into that area and take some tissue from a lymph node that is, they say, has cancer in it. So hopefully it'll be, they'd rather do that than the bone. They just can't get enough tissue in the bone, they say, and besides it hurts.
Right.
So, but some of these lymph nodes are getting smaller with the chemo. And
what about that liver tumor? Is that?
Well, that's it's mostly, I think it's mostly in that pelvic area. They do talk about all different areas. There's a little bit in the lung, but I think they say it's very diffuse and it's not well defined. But they do have a couple lymph nodes. One of them they can access. So they haven't gotten any worse, and a few of the lymph nodes have decreased in size, with the results of about 5 months worth of docetaxel.
Okay. Well, I mean, listen, you're managing the docetaxel pretty well.
Yeah, I am. Yeah, no, I am. I really, I've talked to a lot of the guys on the call, and my approach is to get up off your fanny, exercise, and go to work. And just don't lie around feeling sorry for yourself. And I don't have a big problem with the docetaxel. No nausea, no vomiting, just some stomach pain as I hit the nadir 3 or 4 days out, and a little bit of fatigue, but I try not to let it dictate my life. And since there's no end to this docetaxel, for me anyway, that's what they say, until my PSA upticks, and then they'll switch to carboplatin, I'm sure. So that's the way it goes.
How many cycles have you been through now?
Oh, I've been through about 15, I guess, something like that. Every 2 weeks. Every 2 weeks, Rick. And I just had one today. But in about 3 days, I know this nadir is going to come, and I just get a little more fatigued.
Okay.
Otherwise, it's not. I mean, so many people get this stuff. I handle it pretty well.
You still have your golden locks?
It's getting. You're going to see me in March. But it's not all gone. I mean, it's just slowly. It's turning white. It's turned white. And I haven't lost it with docetaxel, so it's getting thinner, but I still use a hairdryer. It's got to count for something. But they tell me with the carboplatin, boom, it's going to be gone. But no, I got to look professorial. It's a word I made up.
Okay, Professor.
Yeah. Well, we'll see you in March, Rick, and we'll take a look.
I'm definitely looking forward to that.
Oh, it'll be fun. You're going to enjoy Canyon Ranch. It's a great place.
Well, I was just with my buddy who works there, and there's a lot of goings on. They sold Canyon Ranch. It's got new.
Yeah, that's right. Yeah, the guy. Yeah, it's a beautiful facility. It's very large.
Yeah. No, much.
And very expensive.
Very expensive.
Very expensive.
Right. So let me keep throwing it. See, we had to pull that out of you, Jim Harrington. That was a good.
Oh, I know, but I'm just.
You know,
yeah.
You did have something to tell us after all, and I
guess I did. And the docetaxel is working. My PSA stays constant pretty much for the moment, so I'm happy.
Well, the last PSA that I have on my notes for you was in October of last year at 2.7. Where are you now?
Yeah, the trouble is, well, that's because I get two different measurements. When LabCorp does it, it's about, it was 3.9, it's 4.2. So it has gone up a bit. When the hospital measure, when the Cancer Institute measure, it's lower. I don't know why. So that's the number that I gave you then, but it's going up a bit. I measured every 2 weeks.
Right. Where are you getting treated? At Rutgers still, or have you?
Yeah, at Rutgers Cancer Institute, and I'm going to go see Dr. Stein now that he's moved up to Columbia Presby.
Yeah.
But I haven't done it yet, and I'm trying to see if there are any trials. First thing I'm going to do is they're going to biopsy for Foundation 1, and I mean, this is really important if I have any actionable genes to find out.
Yeah.
They failed in the first biopsy, and they wrote me Foundation 1 because we talked with them when we were in California, and hopefully this one will be successful.
Good. I hope so too. Anybody want to chat with Jim Harrington?
I'm happy to chat with anybody, and I always enjoy these calls and get a lot out of it. And I'm going to go get acupuncture for my neuropathy and the sleep issue with chemo. It's a bummer. And by the way, Rick, that was I got to compliment you, a wonderful presentation on sleep.
Okay, I will.
That was last week. It was incredible. It was really good.
Well, I will definitely let Ruben know. He's out of town. He went off to Nassau to give us a talk presentation in the Bahamas. So I don't know if he's back yet. I think we may have had better weather than he got in Nassau. But anyway,
I don't know how many people you had on the call, but boy, it was very well done. His slides were very good.
Yeah, so for those of you who did miss it, it's posted on the website. You can listen to the whole presentation and see the slides as you listen to the presentation, and or you can download the slides yourself and just go through the slides. But thank you, and yeah, we were quite honored. Now, interestingly enough, Peter was kind enough to send me today a note that I missed actually when I looked through the email from the UCSF Cancer Resource Center, and they're running a 6-week group on cancer and sleep, not from the integrative medicine group, but from the psycho-oncology group, which is kind of interesting because I know that Ruben and others here in Arizona are pretty tight with Don Abrams, who is the head of the OSHA Integrative Medicine Center at UCSF. But it's not their group that's doing it. But unfortunately, you have to be a UCSF patient, and whilst we have a couple of UCSF patients on this call right now, they are a little far away. Well, Sylvester, no, I don't know. No, Sylvester, you're not UCSF, right? You're a Kaiser person, I think.
No. Excuse me. No, I go to a private urologist.
Oh, right. Okay. So if you know, it's open to UCSF people, but both Peter and John Appler are on Maui, so it's just a little too far for them, unfortunately. Let me let me just make sure there's nobody new on the call, and before I just head off in a direction I'm thinking of going, is there anybody that would like to raise anything, since we have, amazingly, we have a big group tonight and we have half an hour?
Yes, this is Rick. I have a question. Somebody had mentioned neuropathy before.
Yes.
And I wondered, right after I had my second Lupron shot, my ankles swelled and my feet swelled and legs itched.
Mm-hmm.
I've also noticed that my hands in the morning, I feel like, I don't know if it's arthritis or rheumatism or what, I have a hard time gripping things with my hands. Is this something that we're talking about that has to do with Lupron?
It has a lot to do with Lupron, but that's not neuropathy. Although Lupron can cause neuropathy, the symptoms are going to be a little different. Lupron's going to cause you some joint pain, and it's also going to cause you to retain water. And it sounds like the swelling that you're dealing with is related to the water retention. And I don't really, I mean, we usually talk about exercise being very important because I think that helps dissipate some of the water retention. But it's the sort of question that you should be talking to your doctor about. And one of the reasons why we want you to be seeing a medical oncologist is because urologists are surgeons, and they're just not they're not educated in these systemic issues of things like water retention. Whereas if you speak to a medical oncologist, they're trained in internal medicine. They're internists. They're specialized internists. So they're going to be able to suggest to you better remedies for issues with your joints, with water retention. Who else on the call has experienced water retention or pain with your joints when you get up in the morning as a result of the Lupron? Anybody?
Well, Rick, this is Jim Harrington. Yes, I have. I mean, but the trouble is, I have Lupron. I've been on Lupron for a long, long time, and will be forever. And I certainly have some joint pain from it. But I now that I'm on the chemo, I do take prednisone. It's required by the docetaxel, but it's 2 5-milligram pills a day. I have found. I mean, we've talked about prednisone a lot on this call, and some don't want to take it, some do. That's 10 milligrams a day is required, but it's not a lot. I find that it does help with joint pain, but I still have some joint pain. And yeah, I guess you could increase the prednisone. I mean, I know it can help, but prednisone, by the way, I've heard this for the guys on the call who may not know this, but I have a cataract in one eye, and I had my surgery at the end of the month for an intraocular lens transplant. And lots of people have cataracts. The question is, do they do anything? But my ophthalmologist told me that the taking of a steroid like prednisone can hasten the onset of cataracts. I didn't know that, but he said you don't take enough of it or take it long enough to have that happen. But it's an interesting thought. I'd never heard this before, and this is an ophthalmologist talking. And we all may have to deal with cataracts, and in my case, only one eye, and it's a very routine surgery. But I just thought I'd mention that. But prednisone can certainly. I started taking it, and boy, my joint pain, in my knees, particularly going up and down the stairs, was a lot better. But you can ask your doctor about it. I don't know if they want to prescribe it, but it can work.
Wasn't that the case for you, Dennis?
Exactly. Excuse me. Yeah, I was going to chime in and say the same thing for me. Once I started the Zytiga, a lot of the side effects that I seem to be getting from the Lupron, like getting up in the morning and being very unstable on my legs and feeling like they were going to collapse underneath me. I'd have to stand there for a minute before I'd start moving. And same thing if I get out of a car, or if I stand up from go out to dinner and stand up away from the table, and it'd be very unstable. And all of this stuff, and my arthritis pain that I've had in my joints and my hands and my back even have disappeared almost completely. And I'm only on 2.5 milligrams twice a day of the prednisone with the Zytiga.
Right.
So I know it's not the best stuff long term to use, but boy, do I feel a lot better on that.
Right. So Rick.
By the way, Rick.
Yes.
We figured out who caller number 1 is. It's Dennis playing with his 2-phone bingo system.
Okay. I figured that. I figured that. So I figured it was Dennis.
I don't know how he does it, but
he just likes to befuddle you, Jake. He likes to.
It works.
You should know me by now.
That's right. So, Rick, it's an interesting issue in the sense that, first of all, I don't think you're going to get much sympathy from the urologist if you talk to him about prednisone. Secondly, the reason these gents are on prednisone is because they're all using Zytiga, and Zytiga requires a small dose of prednisone to stimulate the adrenals because it suppresses the adrenals. And it's not normal to take prednisone when you're just on regular androgen deprivation therapy, taking Lupron or Zoladex or Eligard or Firmagon or any of the rest of them. At the same time, there are a lot of gents who feel a lot better taking a small dose of prednisone. It's also interesting to note that Dennis is on 5 milligrams daily, twice, 2.5 twice a day, and Jim's on 10. And the reason for that is that some more recent studies that came out regarding Zytiga used the lower dose of prednisone, and it was found to be just as effective. And so some of the docs are aware of that and are prescribing smaller doses of prednisone, and they seem to work. So, whether you would want to raise it with, I mean, possibly once you've got a medical oncologist, and if you're still suffering the side effects, and you've got a GU med onc, you might want to raise it with it. I somehow don't think you're going to get much of a warm response from the urologist if you raise it with him.
Okay, thank you.
Sure. Anything else? Again, any? I mean, it's great. You guys are coming up with good stuff. We're scraping the barrel a little bit today, but we're coming up with some good stuff. Anyone else want to talk about anything before I raise the issue that's on my mind? So, what I wanted to sort of talk about, and I think some of you have read the studies, are this whole issue when you have recurrence and metastasis, what you do first. Because there's been some recent studies, like in the past week to 2 weeks, that have come out. And the most interesting one, which is a follow-up to the CHAARTED, now seems to suggest that chemotherapy, when you have low volume disease, if you remember in the old CHAARTED study, it looked at people with low volume disease and high volume disease. And if I recall, and somebody I think can correct me, the low volume disease was kind of like oligometastasis. I think it was 4 or 5 Mets or fewer. And the high volume disease was beyond that. And what this CHAARTED study follow-up suggested is that the chemo doesn't really make a whole heck of a lot of difference in terms of overall survival for people with low volume disease, but it does make a big difference for people with high volume disease, which is a pretty significant observation. And by the way, this was reported by Mike Scott on New Prostate Cancer International. And Len, if you could be kind enough to maybe post it in the chat window, that would be helpful, because I know you saw it and you sent it to me. I'd seen it, but if you could just find it and put the reference in the chat window, that would be terrific.
Okay, I'll look for it, Rick.
Thanks a million. And for those of you who are on the phone, if you go to New Prostate Cancer International and you search under CHAARTED, you'll find a post this week. So, what it's suggesting is that chemotherapy can be really effective if you have a fair amount of disease when you're diagnosed, but if you don't, it isn't so effective, and then that starts to suggest that maybe giving people chemotherapy up front if they have micrometastasis, serious disease, somebody like Rick, for example, who has 5+4 disease and enough of it, would you give him chemotherapy just like they would probably do if that was a breast cancer diagnosis? And this most recent trial result, which is a follow-up to the original CHAARTED, would suggest no, not yet, which of course has always been the protocol for treating high-risk disease. I mean, there has been more recent discussion. Well, how early do we give chemotherapy? And then there was another study that I saw today that that Scott had posted, but it didn't do much for me. It was really about should you take chemo or should you take a second-line anti-androgen? And the way that I read it, it was very inconclusive. And I guess what I still rely on is the original work, which I still don't think has been disproved, which is that the chemo makes a much bigger difference. But now clearly we know that that's really only for people with high volume disease. So I know some of you have read this, and would anybody like to comment or talk about these studies that we've just seen?
This is Jake. I'm not sure which one I saw, but one of those studies extended the efficacy period from about 28.6 months to 58 plus 6 months or something. I think it's one of those two that you're referencing, Rick. Am I right?
I didn't see it go out that much, but it could be.
Yeah.
Now, was that overall survival, or was that disease? Was that for disease-free progression?
Overall survival, I believe.
Wow.
Yeah.
Well, I didn't see that, but if you could find that one and send it to me, I would reread it.
Okay.
But I mean, that's obviously we're talking huge amounts there. Len, does 58 months? Thank you for posting it, for posting the reference in the chat window, Len. Does that 58 months, does that ring a bell with you at all?
Yes, I was just rereading it because I kind of forgot what it said, but hold on just a second. So just to recap, let's see how they defined low and high. Either 4 or more metastases to bone with at least one outside of the vertebral or vertebral column and pelvis. That is defined as high volume.
Right.
And by default, anything other than that was low volume. But in any case, all are metastatic. Right. And so for those with low volume metastatic disease, there was no overall survival benefit observed after 53.7 months. However, for the median overall survival for patients with high volume disease was 51 months for those receiving a combination of chemo and hormonal therapy, and 34.4 months for those receiving ADT alone.
Right.
So there was benefit for the high volume disease, which is 4 or more meds.
Right.
And no benefit for the low volume.
Okay. So let me just clarify then. So Jake, you're right. They did talk about that 51 months, but what I'm looking at is the difference between A versus B, and that for high volume guys, adding chemo made a difference of 17 months overall. 34 months versus 51 months. And that's what we've always said on these calls, that the studies seem to show that if you've got, and now I mean, we haven't always said high volume because we didn't know high volume, but the studies seem to show that if you add chemo, that's where you get the biggest bang for your buck. Now, again, you've got to wrestle with whether you want to undergo chemo or not. And you know, we've heard, for those of you who've listened to the discussions with Alicia Morgans and Chuck Ryan, et cetera, you know, the doctors seem to say, well, look, if a guy gives us some pushback and they don't want to undergo chemo, then we'll say, okay, just do the second line anti-androgen. And what we're saying is, well, the chemo can make a huge, huge difference. Was this, just remind me, Len, was this chemo plus ADT versus second line anti-androgen versus ADT?
No, this was first line in both cases.
So it was just first line anti-androgen versus first line anti-androgen plus docetaxel.
Correct.
Right. So that's where we know. Now, we know that when you add the Zytiga, the difference seems only to be, or the enzalutamide, this difference seems only to be about 4 or 5 months. But that could be changing. We're expecting some results on enzalutamide to be announced at the Genitourinary ASCO meeting in San Francisco that starts next week, I think. And there are going to be 3 or 4 papers. But to the best of my knowledge, you know, even the paper that came out last year at ASCO, where they recommended Zytiga, that there was more justification for Zytiga, I don't think it was a lot more than 4 or 5 months. Does anybody remember that?
That's what I remember. Is it was pretty low. I think 4 months is the standard, is the cutoff for where they say they'll approve something.
Right. Right.
Rick?
Yes.
As I recall, the 4 months survival advantage for Xtandi and Zytiga was true when they did the initial trials for the original approval of those drugs.
Right.
But later, when they tried using at least Zytiga up front, then it showed, as I recall, 18-month survival advantage.
I didn't think it was much of that. I have a cheat sheet on my desk that has, I do remember that one of the problems was with the Stampede and the Latitude, which were the 2 studies that came out last summer, that they didn't measure in terms of overall survival. They used different endpoints. So, and I'm just looking at this. I mean, for example, what they showed was in the Stampede trial that there were 262 deaths from if you were on ADT alone versus 184 deaths versus ADT plus abiraterone plus prednisone. And they showed that 535 men, their disease progressed on ADT over whatever period it was they were looking at. I think it's 40 months follow-up, versus 248 men whose disease progressed over the same. But what they didn't do is they didn't measure it in terms of difference in overall survival. And I think that was one of the problems with that Stampede trial. I mean, the Latitude trial, and again, I'm just reading from my cheat sheet. They had radiographic-free progression, meaning how long did it take before scans showed more disease? And for men who were on ADT alone, it was 15 months. And for men who were on ADT plus Zytiga and prednisone, it was 33 months. And what they showed was that the average overall survival for radiographic-free progression, the average overall survival on ADT alone was 34.7 months, and they hadn't reached a point that they could measure on overall survival when they cut off. So we don't really know how many months better it was. That's how I read it, and I think that's one of the problems. You know, you got different measurements, different endpoints, and but as an advocate, the observation that I make is that the chemo seems to have more bang for its buck, which is what we basically usually, we always say on here. But you have to trade that off against, are you willing to do chemo? And there's a lot of people who are not willing to do chemo. But I think if you are, you're going to get the biggest benefit from it. So I'll throw that open.
This is Peter. To me, it brings up the question of, is the wisest thing to throw the kitchen sink at this disease? Just try to really blast it with whatever you can, and that's often the attitude that the guys have. I certainly a little bit of that in me, that whatever it takes, do it. It makes me wonder about some things like why certain drugs, why for instance Xofigo is only used later on when you've got Mets and advanced disease. Why not you experiment with a drug like Xofigo or a therapy like Xofigo when you're early on, and your immune system can take a boost? Are they experimenting with things like that?
Well, I mean, Peter, I think one issue with the Xofigo is, I mean, it's designed to be aimed at the disease. So if you don't have any disease, would you want to do it? I mean, what's it going to destroy if there's no disease there? And the problem with the Xofigo is because it's calcium sensitive, it destroys your bone marrow. And if you've got no disease in your bone marrow, why bother with it?
Okay, I think I had a brain, I was wrong. I'm talking about the immunotherapy.
Provenge.
Provenge, yeah.
Okay, sorry.
Yeah, it was my fault. I slipped.
Okay. Yeah, I mean, good point. Valid point. Again, the earlier you get the Provenge, we seem to think the better it is. I mean, this is an old story.
Right, but they usually don't let you take it until you're pretty far along with your disease.
Right. Well, I mean, you need to have 3 successive increases in your PSA once you're on hormone therapy. So you have to have clear evidence that your PSA is rising, and so that you're castrate resistant.
Hey, Rick?
Yes.
I just pasted in an extraction of the data on using Zytiga upfront, if you want to give that a read.
Go ahead. I'll let you read it out.
Okay, well, basically, apparently they did do a 3-year survival comparison using Zytiga upfront, and they said survival rate increased to 83% after 3 years compared to 76% with ADT alone. And then he said, we think this is one of the biggest survival benefits ever reported in a trial of an adult solid tumor. They also mentioned what I think you alluded to when they said, let's see, where is it? In Latitude, nearly 1,200 men show that Zytiga added to ADT more than doubled median progression-free survival to 33 months compared to 14.8 months. So that's progression-free, but this other piece says that there's an overall survival benefit of 83%, 76% after 3 years.
Yeah, but 76% versus 83, 76% of men survived on ADT alone, and 83% survived on ADT plus prednisone plus Zytiga.
Yeah, I know it doesn't sound that huge, and yet he says this is one of the biggest survival benefits ever reported.
Well, and again, I think that most of the guys on this call would prefer to hear it in terms of overall survival. How much longer did people live if they took the Zytiga and prednisone? And that number still seems to, I don't know that we've got anything that says 4 to 4.4. I think one was 4 months and the other was 4.4 months. And why don't they measure it that way? Because that's what is significant. I mean, guys, all of you are interested in these trials. How would you like to hear the results? What is the most meaningful to you?
Yeah, I agree with you. It would have been better if they indicated the number of months extension rather than a percentage of who survived and who didn't. It makes it more obvious.
I agree too. Yeah. It's much better to hear that you're going to live longer than they're playing the odds.
Yeah, what this...
Wait, now, Rick.
Yes.
Rick, here's another part of the article. It said, quote, the benefit from early use of abiraterone, Zytiga, we saw in this study is at least comparable to the benefit from docetaxel chemo, which was observed in prior clinical trials. But abiraterone is much easier to tolerate, with many patients reporting little or no side effects.
Well, that would say that you're getting anywhere from 13 to 22 months overall survival out of it. But why don't they report that? If that's what they're saying, then they've got to say, okay, well, here's the guys that we gave ADT alone. This was their overall survival. And here's the guys we gave ADT plus Zytiga. Here's their overall survival. So the question is, does that trial say that or show it? And if it does, then, we'll start saying to guys, hey, it doesn't matter whether you do Zytiga or chemo.
Yeah, unfortunately, those trials are not comparing apples to apples because, as we just learned, there's actually no survival advantage to patients with metastatic but low volume disease to adding chemo to ADT. So, yeah, it's complicated.
Well, I've been thinking about asking Alicia Morgans to come on one of our calls. I think I could probably get her to do it. And so if we do that, I don't know whether we could call it a plenary, because it's not going to interest most of the guys who are not, at least as a minimum, on androgen deprivation therapy. But we'll figure it out. We may still devote a fifth Monday to having her on, and it'll be a prostate cancer advanced group plenary. That's what it'll be. But I think I could get her to do it. And I may be able to get Chuck to do it, because I'm going to do him a little favor when he moves to Minneapolis. Most of you, I think, have heard me. I mentioned it before, but if you don't know, Chuck Ryan is taking over he's going to head up the oncology group, all oncology, all cancers at University of Minnesota. And so I offered to introduce him to a couple of people, including somebody that might fund some of his research. So if I do that, then he owes me one, and we could get him on. But I think Alicia would come on right now. So, because she kind of likes what we're doing. And she's the sort of person to ask. She's going to be that's exactly the sort of person, because they know these studies inside out, and she can say, oh yeah, this study showed this, and this, and then we'd hear it from a really good source. But it's very confusing, and I can tell you, if you're not already confused enough, I do think we're going to hear some really interesting stuff over the next couple of weeks coming out of San Francisco. I think there's going to be a lot of stuff coming out of San Francisco. Well, it proved the direction I wanted to go in actually did prove quite useful. Hopefully, well, to me it certainly did, because it helped me rethink this stuff. I hope it proved useful to the rest of you that were listening in, and thanks a lot to Len and others and Peter for just doing some quick research on the fly as we were moving along here. Next meeting is the 13th. Day before Valentine's Day. Len, please, if you have the opportunity, you'll talk to the group, to the congregation or the people that are there, and convey Answer Cancer's condolences, and we wish Pam the very best, and thank you very much for attending on our behalf tomorrow.
I sure will do that, Rick.
Thank you. And the rest of you, Rick, we'll add you to the list, and keep coming in. I hope this was useful to you, and I'll speak to you all on the 13th. We have a caregivers call tomorrow. Oh, and let me just remind you, we have an inner conversation call on Wednesday, right?
Wednesday, 8 o'clock. That's all cancers.
All cancers. So we've got an all cancers call Wednesday at 8 o'clock, and the next prostate cancer only is the following Wednesday, the 3rd Wednesday. So
second Wednesday. The prostate cancer is 2nd and 4th Wednesday.
Oh, okay. Oh, that's okay. Okay. Excuse me. So the 7th tomorrow is all cancers, and the 14th, a week from Wednesday, is prostate cancer only.
That's my understanding of it. Yeah.
I'm sure you're right.
I'm calendar challenged, so I don't know. Don't quote me on that, but yeah.
I think you're right. I think you're right. My job is to confuse everybody. All right. Okay. I say good night to everybody. Thank you for attending. I'll speak to you soon.
Thanks. Thank you, Rick.
Good night, all.
Bye.
Good night, all. Thank you.
Good night.
Thank you.
Thank you, Len.
Thank you, guys. Good night.